I guess this is our last lab review of the semester. Imagine that we are on posterior abdominal wall and diaphragm. We have a lumbar plexus we'll talk about today, and we have a nice mnemonic to help us memorize it. All right, let's get started. Lab 20. So can you summarize the anatomy of the posterior abdominal wall and diaphragm? And then can you relate retroperitoneal structures found in the posterior abdominal wall region? All right, so we have our, just starting off with the diaphragm, which we can see here. The abdominal wall, posterior abdominal wall is bound by the diaphragm superiorly. Then we have the organs, include the kidneys, we have our ureters, and then we have our suprarenal glands, and then the vessels in this region, we have our abdominal aorta, which we'll talk more about the branches a little bit later on, inferior vena cava. We'll see our lymphatics here and along this side of the aorta, and then our sympathetic trunk, as well as plexes in this region. All right, so not too bad. Just a quick reminder about retroperitoneal organs. We have this mnemonic SAD puckers, so suprarenal, aorta, and inferior vena cava, duodenum, pancreas, uterus, colon, kidneys, esophagus, and rectum. All right, but we're concerned with suprarenal adrenal glands and aorta here and kidneys. All right, so let's move on. Can you list the bones that provide the structural framework for the posterior abdominal wall? Well, it's pretty straightforward. These are the bones. We have our rib 11 and rib 12. Then we have the crest of the ilium as well as the iliac fossa right here. And you can kind of see, trace out the boundaries of the framework. Then we have the, so just continue along this. We have the transverse processes and bodies of L1 through L5, which you can see here. And then T11 through T12 as they provide attachments for rib 11 or rib 12 and rib 11 overall. All right, and then we also have the upper margin of the sacrum as the last part of our structural framework. Okay, so can you list the muscles that add structure to the posterior abdominal wall? So we've seen these before. We have the psoas major right here. We have the psoas major is doing thigh and trunk flexion. It's innervated by the ventral rami of L1 through L3. All right, so just a reminder, T12, L1, L2, L3. So innervated by L1 to L3. Then we have psoas minor, which we can see here. And this is doing weak trunk flexion, and it's innervated by the ventral rami from L1. All right, moving more inferiorly, we have the iliacus, and that is doing thigh flexion and trunk flexion. It's innervated by the femoral nerve, which has its origins of L2 to L4, as we'll talk about the lumbar plexus later on. And then we have the quadratus lumborum muscle, which is also doing trunk lateral flexion, which is doing trunk flexion, but specifically lateral trunk flexion, and it stabilizes this 12th rib right here. It's getting its innervation from the ventral rami of T12 all the way to L4 down here. All right, so not too bad. Let's just take a look at these on the software. So here we have our nice model. We have a rectus sheath. We have to hide these anterior abdominal muscles. We have rectus abdominis, which we're familiar with. Then we have the linea alba tendon. All right, we have our external oblique, we have our internal oblique, and then we get to transversus abdominis. Nice little review. Same thing on this side, external oblique, internal oblique, and then transversus abdominis. All right, and here we can start to see some of the muscles we've been talking about. We have our psoas minor. See if we can see the innervation. All right, psoas minor. So from L1. Then we have our psoas major. Let's see our innervation. All right, and we see first, second, and third. All right, and then we have our iliacus muscle, and then our fascia, our quadratus lumborum right there. All right, so not too bad. Quadratus lumborum, psoas major, psoas minor, iliacus. All right, back to it. So this is the same thing, just in table form. Specifically, we didn't mention we have the attachments. So the psoas major is attaching to the vertebral column, which you can see that here, and then that's TV12 to L4. So makes sense. Distal attachment is on the lesser trochanter of the femur. All right, so right here. And then we see that with the iliacus as well. The iliacus is coming from the pelvis, the iliac fossa. You can see it's attached here. And both of these are doing thigh flexion, as we said, for the psoas major, L1 to L3. Iliacus is the femoral nerve, so L2 to L4. And then psoas minor is vertebral column, TV12 to LV1. So let's take a look. All right, so psoas minor right here, 12, L1. Not too bad. We said weak trunk flexion. And this inserts on the iliopubic eminence, so right here, of the pelvis. And then finally, our quadratus lumborum, rib 12, and then vertebral column, TV12 to LV5, which we can see this guy right here, and the transverse processes of each of those vertebrae. All right, and then just a quick reminder, what does trunk flexion look like? So this is trunk flexion, this is trunk extension. Thigh flexion is coming outwards like this, thigh extension is going backwards like that. All right, but for each of these, you see thigh flexion, trunk flexion, trunk flexion, trunk flexion, and then quadratus lumborum is lateral trunk flexion, and it stabilizes the 12th rib overall. All right, so not too bad. Then we also had these nice cross sections given to us, specifically so we could see the location of the psoas majors. Again, we're looking at posterior abdominal wall, right? So this whole region. And we can see psoas major right here, quadratus lumborum, and then we also have the erector spinae muscle, which we learned about in semester 1. And so the erector spinae muscle are located posterior to the vertebral column, right? You can see it here, vertebral column, it's posterior to it, and posterior to the musculoskeletal framework of the posterior abdominal wall, right, which is this. So basically, erector spinae are in the back. What are the erector spinae muscle? Well, most medially we have the spinalis, and then lateral to that longissimus, and then even more lateral to that is the iliocostalis. And then here's just another, just more drawing diagram, cartoon version of this cross section, but you see psoas major, quadratus lumborum, and then posterior to it all we have our erector spinae muscles. All right, not too bad. And then can you discuss a psoas abscess? So again, we have our psoas major, and what exactly is the function of the psoas major? It's thigh flexion, right, moving your thigh forward, and then trunk flexion overall. And so in this abscess, which you can see evidence of here, right, here's the psoas major on the right-hand side, and then we know that we have psoas major, quadratus lumborum, erector spinae, but compare this psoas major to this psoas major, this guy's full of pus, right? And so in a psoas abscess, pus accumulates between the psoas major and its fascia, and then this causes severe pain when moving the thigh, remember, thigh flexion, at the hip joint. And again, it's a diagram, you can see it there, and a whole lot of swelling, pus in between psoas major and fascia. Causes are infection, tuberculosis of the vertebral column, a staph infection, or strep infection overall. All right, how about the diaphragm? So the diaphragm is pretty cool. We said it forms the superior boundary of the posterior abdominal wall, and we have our central tendon here, our esophageal hiatus, but specifically the diaphragm is anchored to the lumbar vertebrae. So we have L1, L2, L3, and we can see the bottom of TV12 here, right? And so our aorta is going to come through right there. But specifically, we have this ligament, and the diaphragm is anchored to these vertebrae by the musculotendinous crura. And so we have on the right-hand side, we have the right cruce, which you can see here, which is attached to L1 to L3. Then on the left-hand side, we have the left cruce, which is just L1 to L2. And then these left and right cruce make up these arcuate ligaments. So right here in the center, we have the median arcuate ligament. Then we have the medial arcuate ligament, and then finally we have the lateral arcuate ligament. And these are important because we can use them to locate different structures, which we'll talk about in just a second. All right, so as we said, can you discuss location structures that pass through or posterior to the diaphragm? The answer is certainly yes. So starting with our median arcuate ligament, you can see here we have the aorta, and then we have the thoracic duct right there. Then we have our medial arcuate ligament, and under the medial arcuate ligament we have our psoas muscle, and then we have the sympathetic trunk, which sympathetic nerve system, and that runs along the side of the vertebrae, as we saw in both the thoracic cavity and the abdominal cavity here. All right, and then under the lateral arcuate ligament, we have the quadratus lumborum muscle, and then let's look at the underside of the diaphragm. So again, under this medial ligament, arcuate ligament, branching off of the aorta, we have this inferior phrenic artery, which is coming along and providing blood to the bottom of the diaphragm. You can see we have a left and a right one overall. All right, then also underneath the diaphragm, we have the caval opening right here, which is where the inferior vena cava comes through. The right phrenic nerve also comes through in this region. Right, you can see that's innervating the right side of the bottom of the diaphragm. Then we have our superior epigastric arteries, which are coming in through the interior part of the diaphragm. We have, again, our central tendon. We have the left phrenic nerve. And then, let's see. Then we have our esophageal hiatus. And we have posterior vagal trunks that are coming through with it. Then we have the greater splanchnic, lesser splanchnic, and least splanchnic all go directly through the diaphragm, as well as the hemiazygos. And that is it. All right, so then we have development of the diaphragm. So remember, with all the embryology, a lot of what we learn about this is, something goes wrong, we can trace a root cause to development, so embryology. So our diaphragm, we have the septum transversum, which eventually forms the central tendon. We also have the right and left pleuroperitoneal folds, which are going to come in and close. They close this pericardioperitoneal canal on the left and right side. And the left side in particular is prone to not closing correctly. We'll see that in just a second. On the next slide. Then we have this mesentery right here. So posterior esophageal mesentery forms the right and left diaphragmic crura, which again, remember, diaphragmic crura, right, left, anchoring the diaphragm to the spinal cord. All right, and then finally, we have this muscular outgrowth, or muscular ingrowth from the body wall, and this is infiltrating myocytes from cervical somites, C3 to C5, cervical somites. All right, so we mentioned that the pleuroperitoneal folds close these pericardio-peritoneal canals, and this left one in particular is often the cause of a congenital diaphragm hernia if you have it. And so again, congenital diaphragmic hernia, it happens when the pleuroperitoneal folds fail to close the pericardio-peritoneal cavity, and this causes failure to close will allow the gut to herniate into the thoracic cavity, and this is generally, as we said, occurring on the left-handed side. And you can see this here. So this is a fetal abdominal contents, fluid-filled loops of intestines are in the left side of the thoracic cavity overall, and this is a congenital diaphragmic hernia. All right, so diaphragm is developed on this right-hand side. On the left-hand side, you had abdominal contents are inside of this cavity. Maybe it's clear as mud. All right, so hiatal hernia is a little bit different. We said we had the esophageal hiatus. So basically, if the esophageal hiatus is lax, meaning not closed well, a portion of the stomach, typically the cardia, right here, and sometimes the fundus, will move up through the esophageal hiatus into the thoracic cavity. And so you would get something like this. It's bulging out of stomach above the diaphragm in the thoracic cavity. All right, can you list the branches of the abdominal aorta and categorize into paired and unpaired branches? All right, so we know that the abdominal aorta is coming under the median arcuate ligament of the diaphragm, and we have a number of unpaired branches. Those are the celiac branch, we can see coming out here. Then we have the superior mesenteric artery, which is our second unpaired branch, and then down here we have the inferior mesenteric artery, IMA. Okay, then we have our paired branches, starting with our inferior phrenic arteries, which we know branch off of the abdominal aorta. Right, it's a paired branch. We have a right and a left. Then we have our middle suprarenal arteries going to the suprarenal glands on top of the kidneys. Then we have our left and right renal arteries. Then we have our gonadal arteries coming off of the abdominal aorta. These are all coming off of the abdominal aorta. And then we have 4 pairs of lumbar arteries, which you can see here, also coming off of the abdominal aorta. And then here's just an extension of that, the median sacral artery off of the lumbar arteries. All right, so unpaired branches, celiac, superior mesentery, inferior mesentery. Then we have our paired branches, inferior phrenic, middle suprarenal arteries. Remember, we also have superior suprarenal and inferior, but they have different origins on the left and right side. And then we have our renal arteries, our gonadal arteries, testicular or ovarian, depending on if you have a male or female patient. And then we have a lumbar artery. All right, so what if something goes wrong with one of these paired arteries? Well, we have 2 symptoms, syndromes that we can see in the clinic. We have nutcracker syndrome, which is compression of the left renal vein between the superior mesenteric artery and the abdominal aorta. This is going to cause flank pain, and then blood in your urine, hematuria, and then left-sided varicocele. So I didn't know what this was, but we just take a look here. You can see superior mesenteric artery is pinching the left renal vein, and you're like, okay, well, if you can't get return here, then it would make sense that blood would go out through the urine. But then we also remember So blood flow to our testes, this is varicella. This is basically pinching here will cause swelling of the veins in the testicles. So varicocele, basically, if we have poor drainage here, this is going to affect the veins connected to it. So varicocele, swelling of the veins in the testicle. Not fun. All right, then we have SMA syndrome. And so this is compression of the third part of the duodenum between, again, the superior mesenteric artery and the aorta. This causes intermittent intestinal pain, typically postprandial, aka after eating, and then it's more common in patients with low body fat, meaning less padding, allowing this guy duodenum to get pinched. All right, what about an aortic aneurysm? All right, so remember, aneurysm is a bulging of our vessels. So an aortic aneurysm is, abdominal aortic aneurysm is a bulging of our abdominal aorta. And so here you can just see, swelling with the abdominal aorta. A rupture is going to be fatal. Here we have these little white dots, which, as you know, these are calcium deposits on the abdominal aorta. And then here we have a metal graft has been placed around the abdominal aorta to support it and keep a rupture from occurring. It's pretty cool. All right, can you describe the tributaries of the inferior vena cava? So this is kind of a mess. I apologize for the slide, just hard to label it without making it look messy. But starting down here, we have the right femoral artery. Then we have, tracing that upwards, we have the external iliac artery. So just renaming it, again, on this side, we have left femoral artery and vein. Care about the veins right now. And then trace it upwards, we have the left external iliac vein. Then, those become common iliac vein, which we can see over here, and then become inferior vena cava. All right, so right and left femoral, then external iliac, then common iliac, then IVC. And then we have a number of tributaries along the vertebrae here. So we have the iliovertebral vein coming in. We have lumbar veins. We have the ascending lumbar vein overall. Then we get further up, we have the left and right renal veins, which we can see here. Coming down, we have the azygous vein, which we're familiar with from the thoracic cavity, and then the hemiazygous vein. And then, continue to trace this up, just IVC. Then we have the, going into this from the liver, we have the hepatic veins, and then these guys are the inferior phrenic veins draining the underside of the diaphragm. All right, not too bad. Can you apply clinical or anatomy knowledge to talk about a deep vein thrombosis? All right, and its prevention with an IVC filter. All right, so deep vein thrombosis is when you have a clot in the venous system of the legs or pelvis, and so the fear is, trace this upwards, that one of those clots is going to go upwards and then get to your heart, at which point, you're in big trouble. So you can install an IVC filter, which we can see here, and the idea is that this can catch a significant clot, and you can see it installed here in the IVC, and then once you caught it, then you can use different drugs to dissolve the clot and keep it from being an issue. All right, can you discuss the May-Thurner syndrome? All right, so the May-Thurner syndrome is compression of the left common iliac vein. Right, so IVC branches into left and right common iliac veins, and this is compressed by the right common iliac artery against LV5. So right here, so we can see that the vein is pinched by the artery, and then again, this is the left common iliac vein, so it being pinched by the right common iliac artery against LV5. And so the result is you have poor venous return from the left side. So you can see that this poor lady or poor person has got a swollen left lower limb. And so you'd say, well, you have poor venous return from the left side, and that might be May-Thurner syndrome. All right, how about the retroperitoneal lymphatic trunks that drain the lymph from the abdominal cavity? So we really have two ways of classifying this. We have two channels, and so in particular, we have the two channels of abdominal lymphatics. We have pre-aortic, which is nodes along the abdominal aorta. So if it's along the abdominal aorta, we call it pre-aortic, and this gets lymph from the GI tract and the accessory organs, such as the liver, gallbladder, pancreas, and spleen, and then those will eventually come together to form the central intestinal trunk, which will drain into the cisterna chili, which all of these drain into the cisterna chili eventually, which we know then goes into the thoracic duct overall, which we can actually see the first part of the, or the tail end of the thoracic duct right here, connected to the cisterna chili. So all this drainage will go to the cisterna chili, which will go to the thoracic duct, right, which we know will eventually drain into the venous system and the thoracic cavity. All right, so we said two channels. There's the pre-aortic, and then we have the para-aortic, and para-aortic is lymph nodes that are lateral to the aorta, and we call these the right and left lumbar nodes. So nodes lateral to the aorta and IVC. This gets lymph from the body wall, kidney, suprarenal, and testes and ovary, and as we said, this form the right and left lumbar nodes, and overall we call those the left and right trunks. All right, so we try to label these, but again, basically our categories are pre-aortic lymph nodes or para-aortic. So pre-aortic on the aorta, para-aortic adjacent to the aorta. All right, so everything here in green, celiac nodes, superior mesenteric nodes. This is just general pre-aortic nodes. Common iliac nodes, external iliac, inferior mesenteric. All of these we'd say are on the aorta, so we call them pre-aortic. And then para-aortic, we have right lumbar trunk, right, all of this guy right here, and then left lumbar trunk we can start to see here. These lateral lumbar nodes that are adjacent to the aorta. All right. The challenge, though, is, as we'll see in a second, these guys being associated with the aorta means that they are very difficult to remove. And so if lymph nodes do need to be removed, we target the para-aortic, the ones that are around the aorta instead of on the aorta. All right. And so there's this surgical procedure called retroperitoneal lymph node dissection, RPLND. And so basically, this is dissection, removal of retroperitoneal lymph nodes, and this is done typically in cases of testicular cancer. And so this is testicular cancer, disease of young middle-aged men. Treatment is chemotherapy and then removal of retroperitoneal lymph nodes, which is why we do this procedure, associated with testicular lymph drainage, right? And so these would be the para-aortic lymph nodes, and so we target the para-aortic lymph nodes for removal from the common iliac bifurcation inferior to the renal veins, all right? So we're going to be removing para-aortic, so not on the aorta, and then from the below the common iliac bifurcation. And so we have this basically two separate approaches to RPL and D. Option one you can see here versus laparoscopic surgery, which you can see here. And so option one is you make this long vertical incision, and then the surgeon is going to take an extraperitoneal route. So basically, he's going to move along the posterior abdominal wall towards the vertebral column. And again, remember, these guys are extraperitoneal, so behind the peritoneal cavity. And so the idea is if you go this route, then you can avoid puncturing the peritoneal cavity overall, which could theoretically be a little bit safer, but you have this huge, long vertical incision. So more recently, we have the laparoscopic surgery, but this is going to be puncturing the peritoneal cavity. But you can see you just have a number of single incision points instead of a long vertical cut. All right, so here we got the lumbar plexus, and so finally talking about innervation. We're familiar with the lumbar plexus previously because we talked about the femoral nerve and the lateral cutaneous nerve, as well as the obturator nerve in first semester. And so the lumbar plexus is T12 through L4, and it actually forms inside of the psoas major muscle. So we can see, it's coming off of the vertebrae, but it's traveling through the psoas major muscle. And then we have, you can see that they're coming out, the branches are coming out laterally, with the exception, there's two exceptions. The genitofemoral nerve comes out anteriorly, and the obturator nerve comes out inferiorly. So we'll see that in just a second. But overall, we have TV12 to L4, and then we have this nice mnemonic called, well, maybe not nice, but I twice get laid on Fridays. And then you pair it with this nerve root key 2 from 1, 2 from 2, 2 from 3. And so before we start the mnemonic, though, we actually have for TV12, we have the subcostal nerve. And the subcostal nerve is associated with rib 12, and it innervates the quadratus lumborum muscle, and then gives us the T12 dermatome, which is suprapubic, which we can see here, T12. Right, so the subcostal nerve, suprapubic above the pubic region. Okay, and quadratus lumborum, this is one of the nerves that innervates the quadratus lumborum. Then to our mnemonic, I twice get laid on Fridays. We have the I twice stands for iliohypogastric and ilioinguinal, and then 2 from 1. Both of these guys, so 1 and 2, two of them are getting innervated from L1. So iliohypogastric, we have, this is going to innervate the, both of them are innervating the same thing, anterior abdominal wall muscles, the transversus abdominis and the internal oblique. So iliohypogastric and ilioinguinal nerve do that, and again, that's I twice and 2 from 1. Then we have get laid, and get is genitofemoral, and laid is lateral cutaneous, and this is 2 from 2, so both of them are have traced the roots back to two separate vertebrae. So genitofemoral is L1 and L2, and then lateral cutaneous is L2 to L3. All right, so genitofemoral nerve does something slightly differently in males versus females. In males, it's going to innervate the cremasteric muscle of the spermatic cord, and then does sensory innervation of the upper thigh, anterior, as well as the anterior scrotal skin. For females, you have sensory only of the mons pubis and then the labia majora overall. All right, and then we said again that the lumbar plexus forms within the psoas major. All of these branches are going to come out laterally, except for genitofemoral, which comes out interiorly. We'll see this better on the next page, and then the obturator nerve, which comes out medially. Okay, so then we have laid for lateral cutaneous, and this is just doing innervation of the skin on the proximal thigh. Here we have 2 additional branches to the iliacus muscle, and then finally we have mnemonic on Fridays. On is for the obturator, and then Fridays is for femoral nerve. And so they correspond with 2 from 3. So obturator and femoral nerve come from 2, 3, and 4. Central rami. And so we have femoral nerve we're familiar with, but it's innervating this whole thing. So part of psoas major, iliacus, rectus femoris, vastus medialis, vastus lateralis, sartorius, and pectineus. And then obturator, we have obturator externus, we have adductor magnus, adductor longus, excuse me, I said adductor magnus twice, adductor brevis, adductor longus, and then this guy right here, which is a drawn in the diagram, but I added the gracialis. Okay, all right, and then here's a tiny little part, the lumbosacral trunk. Okay, so what does this look like on our actual posterior abdominal wall? Again, we said, these form in the psoas major, and we have our nice mnemonic, but starting with TV12, we have the subcostal nerve, which is going to quadratus lumborum. We can see here, that's right there. Then we have I twice. We have the iliohypogastric and then ilioinguinal, and 2 from 1. So this is L1, L1. This is TV12. Then we have get laid. So we said that genitofemoral was an exception to our everything comes out laterally. This comes out anteriorly. All right. So anteriorly, and this goes to the genitals, the cremasteric muscle of the spermatic cord. All right. So it's coming out anteriorly. We can see it's anterior to the other branches. And then we said so get laid 2 from 2. So L1, L2, L2, L3 for lateral cutaneous. So this is L1, L2, L2, L3. And we can see lateral cutaneous is indeed coming out laterally, like all of them do, except for genitofemoral and obturator nerve. All right, then we have our femoral nerve, which we see here, and our obturator nerve. Femoral nerve is coming out laterally. Obturator is most medially. And then this is 2 from 3. So femoral is going to be 3. So L4, L3, L2, and same thing with obturator, L2, L3, L4. All right, not too bad. Hopefully that helped. And then we have the autonomic plexi. So basically we look at these just like any autonomic nervous system, we have our plexi, which are our axons, and we have ganglion, which includes our cell bodies. And so can you write the positions of pre-aortic, so on the aorta, ganglion, and then the autonomic plexuses to the sympathetic trunk in the abdominal aorta. All right, so remember we have our sympathetic trunk going up with its ganglion. Then we have our pre-aortic ganglia, which just means they're on the ganglia, on the aorta. So we have our celiac ganglia. Then we have our superior mesenteric ganglia. We have our aortic or renal ganglia. So the nice thing, these are really just named based on the branches of the aorta. Then we have our inferior mesenteric ganglia, again, inferior mesenteric artery. Overall, not too bad. We already mentioned the sympathetic trunk. We have lumbar splenic nerves coming in off of the sympathetic trunk. And then in terms of our plexi, again, the axons, prevertebral plexi, so around this region, celiac plexi, this region, aortic plexi here, and then superior hypogastric plexi here. This would be the hypogastric nerve, and then down here we have the inferior hypogastric plexi. All right, then can you review organ relationships in the posterior abdominal wall? All right, so remember TV12 is where the Aorta comes in through the median arcuate ligament. Then we have L1, L2, L3, L4, L5, and then we have the sacrum. So a whole bunch of different things going on, but let's just start with the organs, I guess. So we have the spleen, we have the pancreas, we have the left kidney here, we have descending colon, then we have ascending colon, we have duodenum, different parts, the proximal, aka superior, we have descending duodenum, we have transverse, we have ascending duodenum, then we have our vessels, inferior vena cava here, we forgot the gallbladder, common bile duct, then we have the major duodenal papilla, where the common bile duct and the pancreatic duct meet up and drain into the descending duodenum. Okay, minor duodenal papilla is for the accessory pancreatic duct, if it exists, draining into the descending duodenum, and then missing anything, we have our vessels, abdominal aorta, bifurcation at L5. Then we have our superior mesenteric artery and vein branching over the duodenum, approximately L2, and I think that's it. All right, so we had a couple of nice little cross sections here. It's just a reminder we need to practice this before the practical exam. And so I'll just point out a couple things. Here we have inferior vena cava, aorta, psoas major, quadratus laborum, erector spinae. We have a little bit of kidney, inferior vena cava, aorta, superior mesenteric artery, or excuse me, superior mesenteric vein, superior mesenteric artery, rectus abdominis, abdominal wall muscles, transversus abdominis, internal oblique, external oblique. This is inferior mesenteric vein. This is left uter. This is right uter. This is duodenum. All right. So the challenge is not only do we need to know this, we need to know approximately where we are in terms of cross section. All right. So then further down, we have a hint, as you can see, the top of the ilium here. So if we're at the top of the ilium, fair to say we have a bifurcation. So common iliac vessels, iliacus muscle. We have a uter here, uter here. Here we have end of psoas major. Inside of the psoas major, we have the right lumbar plexus, quadratus lumborum, more psoas major over here on the left-handed side. Actually, I think that's right. Yeah. No, we're looking from the feet up. So this is left. Okay, then we have inferior vena cava. This is right common iliac. This is left common iliac. Descending colon, rectus abdominis, external oblique, transversus abdominis, ilium, and then ascending colon. All right, so that's it. That's the end. Last lab of the semester. Good job, guys. It's quite a bit. Make sure to practice writing this guy out. Hopefully this mnemonic is helpful, and we'll see you in January. All right, bye, guys.